Chairman, ladies and gentlemen, first of all, thank you for the invitation to be here. It's always a pleasure to be in Italy, especially looking at our miserable weather back home. Second, I have to apologize once again. I have to speak in English, but everyone speaks English anyhow so well that I think we'll get the message across. I have been asked to talk on the utility and limitations of PSA and PSA kinetics in prostate cancer detection in patients treated with 5-alpha reductase inhibitors. 5-alpha reductase inhibitors are standard treatment in BPH. This is a very difficult slide to overview, but what it basically says is that regardless what guideline you take, you will always find 5-alpha reductase inhibitors there as primary treatment, and especially now as we're going into combination therapy, it is being used more than ever. And we urologists all know that at least 50% of the patients we are treating for BPH harbor some form of prostate cancer. And the issue is therefore, are we identifying cancer in these patients treated with 5-alpha reductase inhibitors for BPH? Because, as you've already heard from Professor Montosi's talk, 5-alpha reductase inhibitors reduce the serum PSA levels significantly. This is one of the landmarks studies, the MTOP study on BPH, and it showed that after 1 year and after 4 years, there is a drop of about 50% in patients on 5-alpha reductase inhibitors. And as a result of this and similar studies, the so-called doubling rule was established, which says that if a patient is on 5-alpha reductase inhibitors, you just double the value of his PSA to get a comparison with what it would be without 5-ARLs. Now, this slide already shows one of the potential problems because although this comes down 50%, placebo goes up. So the doubling rule is already a bit unreliable there. But if we go further with longer treatment, PSA tends to go down longer. And this is, for example, shown here in the PCPT data, where patients got at least 7 years of PSA, and you see it went down much further. It went down so much that in order to keep a balance in the numbers of biopsies done for cause, the doubling rule was changed to 2.3 after 4 years. But still, if we take the actual number, we have an area where we definitely have a gray zone, and again, this does not consider the increase in placebo. Nevertheless, PSA in the PCPT trial had a better diagnostic accuracy in high-grade tumors than in low-grade tumors, and that may be another explanation why there were more high-grade tumors in the active drug arm than in the placebo group. I would specifically like to point out this very high area under the curve. You know, the more it is to the left, the better the diagnostic accuracy, and you see that this red curve differs significantly from the white curve, the placebo group. Now, the problem, or a study which answers the question a bit more, is the so-called reduced trial. You've already heard about it, and I can go through it very fastly. It was basically in contrary to the PCPT trial where we had healthy men. These were men who were urological problem cases because they had a high PSA, a large prostate, and had a negative biopsy. They had to have a negative biopsy. And they were put on placebo or on dutasteride and had an automatic biopsy after 24 and 48 months, as you heard, regardless of the PSA. And this, therefore, gives us very good insight on the true incidence of prostate cancer in patients like this. The PSA was measured on a regular basis every 6 months. The biopsies were performed almost exclusively on a routine basis and not for cause-driven. Only 6% were cause-driven. And 83% of the patients had at least one post-treatment biopsy and a negative pre-biopsy. Therefore, this was a much better and much closer surveyed patient group than, for example, in the PCPT trial. Now, you've already heard about the results. There was a significant reduction in the number of low-grade cancers. However, in the 7 to 10 Gleason score, and especially in the 8 to 10 score, Gleason score, this was not significant. In fact, if we look at the absolute numbers, there were 10 more cases of high-grade cancer in the active drug arm than in the placebo arm, and this was not statistically significant, but this was an increase in absolute figures. You've already heard the explanations for this. I'm to talk about the utility of PSA in detecting these cancers. Now, one of the statements from Dr. Montosi I would like to reiterate. The speed of decrease of PSA in the first 6 months of treatment does not say anything. Originally, before these data became available from the PCPT data, there were some thoughts that one could give patients 5-alpha reductase inhibitors to challenge if the PSA came down fast, and if it didn't come down fast, there was a higher chance of having prostate cancer. This was not proven in REDUCE, and as that was the more precise study, that can be refuted. However, if we take PSA, for example, the final PSA after so and so many years of 5-alpha reductase inhibitors, the diagnostic accuracy is still better in the active drug arm, in the 5-ARI drug arm, than in the placebo group. The same is true if we look at, for example, just the high-grade cancers, 7 to 10, although the significance is not as good. When these data first came up, and I was one of the co-authors of this study, the idea was that we would change and take the PSA change from month 6 to the final PSA. And indeed, that did improve the diagnostic accuracy of the results, and especially when we look at the high-grade tumors, which of course are the tumors which we shouldn't miss, it was also highly significant. And this is the area under the curve. You see, this is also a very convincing, better diagnostic accuracy of PSA. But as I said, it has to be looked at in the new baseline 6 months after treatment was started, and from there on to the end point. The problem we have seen with further study of the data is that the patients do not all reach their nadir, the lowest point, at 6 months. But this goes on. This was a 4-year study, and after 42 months, only 97%, not 100%, had reached the nadir. And if we just take the 6 months, in fact, 13% were the only patient group that ever reached the nadir at this time. So we developed a new concept, and that is the concept that we look at the nadir, not the 6 month as the new baseline, but at the lowest point in follow-up as the nadir. Looking at the mean PSA changes, and now this is cancer versus no cancer, in the placebo group and in the active drug arm, you see that there is a significant difference. But when we split it up even more, it becomes very obvious that high-grade tumors tend to have significantly higher cancer than the low-grade cancers, which again, we don't really want to find. The problem in the REDUCE trial are, like I said, really these cases here, these 10 patients difference. We had 29 after in the 5-ARR group versus 19 in the placebo group. Now, I'm not going to go into the explanation for that. Professor Montosi has already done that. But would we have recognized these high-grade cancers with our PSA if we would have used PSA as our indication for biopsy, not like it was originally done, automatic biopsy? Well, when we look at the cancers which we would have missed by taking any rise from nadir, that is from the lowest point, whenever PSA goes up, you do a biopsy. We would have missed about 36% of the low-grade cancers, but we would have missed only 24% of the high-grade cancers. Now, we have to do the same in the placebo group because, again, there also the biopsy was automatically done. One of the standard criteria for using that are the so-called NCCN guidelines, which are basically approved guidelines, also guideline-approved guidelines in Europe, that when you have a velocity of over 0.75 nanogram per year with a PSA over 4 or 0.35 if it is under 4, you do a biopsy. If we use these guidelines, you see this is what we would have found. We would have found exactly the same number. In other words, we would have missed about 24% of the cancers in both the placebo arm and in the active drug arm. And I'm only talking about the high grade, the dangerous carcinomi bruti. These are the ones we have to find. And as you see, there is no real difference between the placebo group and the active drug arm. Now the question is, are we picking up clinically insignificant cancers? And we are beginning to believe that there are even some high-grade, high Gleason score cancers which may not be so aggressive. Well, there was no real difference if you take, for example, the volume on the biopsy in the placebo arm between those which we would have missed and those which we would have picked up using the NCCN criteria. But if we use this nadir or any rise from nadir, you see that the cancers we would have missed, the high-grade cancers, are significantly smaller, have a significantly lower volume. And the same is true if we take other criteria like the number of positive cores or the percent of cores overall with cancer. You see there is no difference in the placebo group, whereas in the dutasteride arm there was a significantly lower group. Now again, the big problem are these differences here. In year 3 and 4, we had only 1 high-grade cancer in the placebo arm, but 12 in the active drug arm. Now remember the figures. We're talking about 8,000 patients with about 1,400 prostate cancers, and now we're talking about 13 cases. If we look at these patients in detail and look at the individual PSA values, you see that with the exception of these two here, maybe this black one too, but these two red ones, and maybe this black one, even though it did show an increase here. Basically, it's only these two, these three. All of them showed an increase from the lowest point. The lowest point was not at 6 months. For example, here it was at 12 months. Here it was even later. But when you take the lowest point, when the flag of alarm goes up and you biopsy the patient, we would have missed only 3 at most of these 12 cancers if we would just have followed the PSA ruling. Now we have to be aware of the fact we're talking about 3 cancer cases out of 1,400 cancer cases. There are some high-grade prostate cancers that lose the ability to produce PSA. They're very aggressive, and we will probably always have this number in there. And we also had them in the placebo arm, only they were detected earlier. But what has REDUCE shown us? Number one, the drop in the first 6 months is irrelevant. Patients receiving dutasteride must have a new baseline PSA at 6 months. Any confirmed increase from the lowest point in the follow-up, that is the nadir, should raise a red flag of alarm. This patient is potentially harboring prostate cancer, and he should be diagnosed appropriately. And we can very clearly say that if this is done, the ability of PSA to detect prostate cancer is certainly not poorer. It, I think, is improved. And this has been shown in the meantime with a number of other studies. Now, always remember, REDUCE is not real life because we do not automatically rebiopsy our patients regardless of PSA. We do it PSA-driven. Here, for example, a trial, another prospective trial where patients were treated for BPH with an alpha blocker, with 5-alpha reductase inhibitor, or the combination. And these patients only had a biopsy, well, if they had an indication for it because the PSA went up. And here are the results. You see, again, predominantly low-grade cancer, and most interestingly, especially in the alpha blocker group, but there was no higher incidence of high Gleason score cases, especially 8 to 10, for example, in the combination arm or in the dutasteride only arm. So that in conclusion, one can clearly state that the 2 trials we've talked about have clearly shown that we can detect high-grade cancers under 5 ARIs. They are apparently higher in these trials. You've heard the reasons. I'm not going to go into it. But overall, clinical studies have not really confirmed this. Now, we have one news trial which was just published, which is a prostate cancer trial. This is an active surveillance trial where patients who had low-risk prostate cancer were subjected to randomization to a placebo or a 5-alpha reductase inhibitor and had a biopsy after 1.5 and after 3 years. And of course, they had a positive biopsy before. And if we look at the results here, we see no significant increase or no increase at all of high-grade tumors. Now, this is real life. This is the way we really treat these, and these are patients with proven prostate cancer. So to summarize it, how do we use PSA in men taking 5-alpha reductase inhibitors? First of all, there must be a new baseline PSA 6 months after they have started the treatment. And any confirmed, and I really state or stress the point confirmed, you should do it twice, and you have to ask the patient, have you really been taking your 5-alpha reductase inhibitors? Because if he only takes them every second month, you cannot use these rules, and then you don't know what you're doing. But if there is an increase from nadir and the patient has been taking the drugs, that should raise the red flag, and the biopsy is needed. And in the interpretation of the PSA, the individual PSA value, how much increase should there be? Of course, you need medical judgment and other risk factors like age and so on. Thank you for your attention.